Hey, Josh. Hey, David. Thanks for having me.
Oh, there you are. Great. Andrew is the CEO of Buoy Health. Is it Buoy? We say Buoy. I mean, I know it's a common parlance word, but how it's pronounced Boy, right? Boy. Well, you could pronounce it different ways, actually.
Yeah, the American pronunciation buoy. Like the thing.
Buoy. Okay, right. There you go. So, quickly give us the summary of what Buoy Health has done in its history, and talk about the pivot you've made around COVID.
Sure. So what we do in our day job, kind of working back to the founding of the company, I started the company when I was in medical school, when I was seeing all these patients who were Googling their symptoms before going to the doctor. And based on what they were reading online, they're doing the wrong thing almost universally. My dad got really sick right around then, didn't go to the doctor at the right time. And I actually took
I mean,
this.
they just Google their symptoms and then they just do whatever and don't even call a doctor.
Right.
Yeah.
So the problem that I just became obsessed with was that when you get sick, you all of a sudden have to turn into both a doctor and then an insurance expert in real time to understand the best next action. And because both of those things are really hard, healthcare is super complex. Your human body is super complex. It's really hard to do. We, as a society, 72% of Americans actually just start by searching online, reading some flat content, and then making a best guess. So we built this AI program that chats with you like a doctor. It's built off of thousands of clinical papers and now millions of patient encounters, helps you figure out clinically what's most likely going on. And then by understanding your insurance or who you work for, we can then navigate you to the best provider that's in network for you if you actually need one. In January, we were seeing what was happening in China and
But
said,
before you go there, you took that and partnered with a lot of major health providers around the country who have been making that available to their members, and it's been in active use for some time.
Right. So we launched that product in March of 2017. We have about 9 million active users on our site. We're backed by United Healthcare, Cigna, Humana, Fidelity, and have been in market for some time, helping people get to the right care at the right time.
Great.
And from an efficiency perspective, we save healthcare $174 every single time someone uses Buoy, because they get to the most appropriate next action, as opposed to, again, kind of shotgunning into healthcare, as we call it. What ended up happening in January was we saw, the effects of COVID in China and said, this is definitely going to come to the United States. So we took the CDC guidelines.
Somebody thought that, but go on.
We took the CDC guidelines for COVID and incorporated them into our product and launched that in early February. In our audit of the space, we're the first digital health company in the United States to actually roll out a COVID-specific product. And because we had these 9 million users, what was fascinating, David, was that we actually started to see the spread across the country. So we would see pockets of high risk on Buoy shortly before a confirmed case would pop up in that area, happen across 17 different states. What ended up happening after that was large government entities and large payers started asking us to roll out our navigation product for their population. So in the course of 3 or 4 weeks, we rolled out as the COVID navigation product for the Commonwealth of Massachusetts, United Healthcare, Cigna, Humana, Optum, Express Scripts, and then a few weeks ago, we launched with the Commonwealth of Virginia to basically help people from a user perspective. Look, I have a fever. I have no idea what to do. Here's the likeliest, what the CDC says I should do. Once I put in my insurance information, here's the provider I should go see. Here's how I should get testing. And that's what how we responded to COVID. About 2 months ago, the state started asking us to think through reopening. And we started interviewing a lot of employers to understand, how are you thinking about kind of reopening in this 6 to 18 month window where there's not going to be a vaccine fully distributed. I mean, throughout the entire population. It's going to be a slow burn in which you're going to try to reopen, where COVID is going to be a stark reality. So we started developing our product to actually now enable employers to reopen safely, which constitutes kind of 2 components to that. One, helping employees understand whether it's safe for them to come back to work. And if it's not safe for them to come back to work, our AI actually takes care of them, helps them figure out what doctor to go see, helps them self-quarantine correctly. And on the employer side, employers, the decisions they're making are super complex. you're thinking about, infectious diseases, epidemiology, health equity, behavioral economics. And so we actually built an employer-facing product that helps them understand the risk that they have per office location.
Per location, right down to the individual office. Yeah.
Exactly. Such that if they could see that, okay, in my New York office, I have a bunch of healthy people in my, young, healthy people in my New York office, and the case rate in New York is actually falling. And so I can actually see that my risk is falling in New York. And thus I could actually be more aggressive and start to bring more people back to my New York office. But my Texas office, the rates are rising. Maybe my employees there are more symptomatic. And thus I should actually reduce the number of people that come back. And you're doing that at a time period before, let's say the alternative, you waited 3 weeks, 30% of your population test positive. That would be a terrible outcome.
But just to be clear, each employee has to fill out a form every morning before they go to work in order for this to work properly, right? But in the process, you're building these vast databases of what kind of symptoms people have, what happened, and presumably you're going to also track if someone with this symptom ended up going to work, how did that affect the population health of that workplace? And you're going to, I know, work on gaining some pretty important, actionable, big picture public health recommendations as this thing continues. Was that fairly said?
Exactly, David. So at the employee level, if we're helping them make a decision daily, whether they should come into work or not. And at the employer level, we know what strategies they put in place. Are they requiring masks? Are they requiring gloves? Are they doing, mask wear? How big is their office? How many people are they bringing back per location? You have enough variables there if you then understand how many people are getting tested and what their results are to say, okay, here are all the inputs into your strategy. Here's the level of disease in that particular community. Here are the symptoms that are presenting. You could actually now start to uncover what works and what doesn't work. Yeah. And when you think through, again, the complexity at the employer level, most of our understanding of COVID and how to respond to it is at the country level, right? It's like, what did Taiwan do? What did Singapore do? Now coming to the United States, the federal government hasn't given much direction. The states have a lot of leeway. The states are also, with a lot of variability, giving most of the decision-making, to the employer. At the employer, how am I going to take what Singapore did and now apply that to my bank? Or how am I going to apply that to my brewery or my construction company? It's not straightforward. So to give them the tools to make the best data-informed decision today, but then to iterate with them over time, to continue to get better at helping their employees come back in the safest possible way is our charge in the next 6 to 18 months.
Yeah, and the reality is this could be done at any scale, and the more scale it was done at, the more we would all benefit from it. I know you even expect that scientific papers will be written based on the data that you're accumulating, and you have a scientific advisory board now, particularly around the COVID issue. Since one of the questions that came in already in the chat is one that I wanted to ask anyway, I'm just going to go ahead and ask it, and thank you to Steve Dahlberg for prompting me. That's, how can this be applied in schools? And do you think is there interest? Are you getting interest? And could that happen? And what difference would it make?
I think it's very applicable in schools because many of the strategies that an employer has at their disposal are, frankly, there's not that many strategies to look at. There's not that much that we have from a toolbox perspective. Now, quantifying the effect of those strategies, and now it's telling a school like you should, think about, social distancing. That's kind of obvious, but think through how often you're screening people. How often are you doing temperature screens? We're getting a lot of interest from schools. I think one of the challenges, though, is from a product perspective. They're very different from an everyday flow. In that, from a school perspective, the incentives for you to go to school are very different from your incentives to go to work. The relationship that you have with your employer is different than as a student, the relationship you have with the school. When we talk about higher ed, you now throw in the difficulty of now accounting for the fact that they likely are living on campus. Kind of creates another variable that's slightly different than at the employer level. So what we're hoping is that the science and the research that we're generating from the employer can help inform a lot of the decisions that schools are making. And I actually just got off a webinar with a number of schools, walking them through how we're thinking about from the employer perspective. Bowie personally, we haven't yet built a product that is applicable for the school population.
Great. Really quick question, and I want you to answer quickly because we want to go to Gary Bowles, who has a question. You're talking to a lot of companies. Companies of a variety of sizes have already begun implementing your questionnaire-based tool. How frustrated are companies about what they're having to deal with right now? Because you're talking to them about this every day.
I think it's not a feeling necessarily of frustration, David. I would characterize it more as a feeling of being overwhelmed.
Yeah.
Our clinical team actually did a look at the literature, and since the pandemic has begun, there have been 23,000 pieces of clinical literature published about COVID. It's been the biggest bloom of research in modern history. The problem, though, is that as someone who's making a decision at a company level, imagine trying to wade through 23,000 pieces of literature and make sense of that, in addition to trying to make sense of the fact that the guidelines that you have at the county level, at the state level, at the federal level are changing constantly and may or may not be consistent with one another. On top of the complexity of how much disease is in your area and what the feelings are of your general population, putting all that together, you would have to be an expert infectious disease doctor, epidemiologist, behavioral economist, health equity
Are you
expert.
saying that your product could help them navigate that? Because do you kind of absorb a large percentage of that information in your software?
So even as a private company that is focused on this space, we too were also overwhelmed with this idea of 23,000 papers. And so we actually built, as you alluded to it, David, we built a scientific advisory board. We're based here in Boston. One of the benefits of that is you can't help but walk down the street and run into an academic. So we actually built a team of all of those areas of expertise, kind of world experts in testing, in infectious diseases, in healthcare economics, and behavioral science, and had them actually think through all the literature that they're reading on a daily basis to say, okay, so if now you're an employer and we're building a product on behalf of the employer and the employee, what would you do if you were in our shoes? And so when we think about the 23,000, one expert would be like, I understand these 5,000. I understand these 2,000. I understand this set of the world. And we incorporated that into our product. And then we also incorporated it into how we advise our clients.
Listen, I want to get to Gary real quick because we're keeping the momentum here. You're great. I can't believe how young you are, by the way. You clearly started your company in college. You are amazing. Gary, can we get him turned on?
Yep. Go ahead, Gary. Ask your question.
Yes, I'm turned on.
Yep.
Andrew,
Everyone is when they watch our programming, Gary. Go on.
Yeah, absolutely. Stimulated, highly stimulated. So Andrew, David and Josh know I'm focused on issues related to the present and future of work. What we would ideally like as we're going through this shifting in the workplace is to have just perfect data about everything, people's illness levels and that sort of thing. But generating that data, it raises a lot of questions about data ownership, privacy, and so on. How do you think about that? Does an employee own the data that you're gathering? And when they leave that employer, can they have it excised? Or there's all sorts of negative things that can happen when a whole bunch of information like this, especially related to health, gets stuck in the public record. So how do you think about that?
Great question.
That's such a great question, Gary. And actually, I think this is why there needs to be an intermediary here between the employee and the employer. Because the employer, if they have abstracted information that is de-identified, they can actually make a lot of great decisions if they could see the data in a de-identified, aggregated manner at the office location, as I'm kind of alluding to with this idea of being able to understand your risk day to day. But the problem with that is that how is the employee going to hand over all of that information to the employer? That actually breaks a number of laws about what an employer can ask, what the employer can know. So actually, we, as an intermediary here, have a HIPAA compliant cloud. We're capturing the data from the employee perspective. We are only showing what is actually legally allowed to the employer, but it's largely aggregated, de-identified, and then given back to the employer from an actionable perspective of, okay, here's the increase in symptoms, here's your increase in risk at the location level, but not necessarily saying, David, is taking the subway to work and has these 4 or 5 symptoms, is this concerned about coming back to work, which is completely inappropriate. So having that kind of intermediary there is essential for giving the employer the information they need. But from the employee perspective, feeling like I'm coming into work in the safest way possible, but I'm also coming in without revealing every little thing to my employer in a way that feels awful. And then from an ownership perspective, that data at the individual level is still owned by the individual. Everything that's aggregated is now kind of passed to the employer. But from an ownership perspective, hopefully that answers your question.
That was so good. Andrew, you are doing very important work. I'm so pleased that we were able to hear from you today. Thank you for joining us.
Thanks, David. Thanks, Josh.